Now can you hear me? There I am. For those of you that do not know me, my name is Beth Travis. I'm the Director of Rehab here with Functional Pathways. I am a speech-language pathologist, and I am here with Jennifer Miller. Do you want to introduce yourself?
I'm an occupational therapist.
Today we're going to talk about urinary incontinence. Fun topic, right? Something everybody wants to talk about, but it is an important thing that a lot of people avoid talking about, so we are glad that we could bring this presentation to you all today. So I hope it helps. So urinary incontinence affects over 13 million Americans. Did you know that you're not alone if you have this problem? There's that many people that are suffering from this. Twice as many women than men suffer from urinary incontinence, and it really impacts quality of life. Those of you that have this probably already know that. There are times you feel like maybe you can't go on a certain trip, or you can't travel that far, or you won't be able to stay through a whole entire presentation because you might have to go to the restroom and do not want to be interrupted. So our goal today is to talk about some things that can be done to help manage it so that it isn't affecting your quality of life. Do you want to say anything about that? Okay.
So what is continence? Continence is the state in which you are able to possess the ability to store urine. Can you not hear me? Is that better? Okay. Where you can store urine in your bladder and be able to urinate at socially acceptable place and time. So in order to be continent, you have to be able to hold increasing amounts of urine while you have pressure on your bladder, and then be able to release it when you want to or need to. So some muscles have to tighten for this to happen, and some muscles have to relax. So it's a balance of relaxation in your sphincter muscles and a tightening of the muscle lining around the bladder walls. And then you have your pelvic floor muscles that are like a hammock of muscles that are kind of holding everything in place. So that's what continence is, and you can be continent of bladder and bowel. We're focusing more today on bladder, but you can have this issue with your bowel as well as with your bladder. So urinary incontinence is considered a silent condition because people don't feel comfortable talking about it. It's kind of a hush-hush thing. We spend, I think the last thing I read was like, it's $1 billion industry on buying products to help with urinary incontinence. The Depends, the Poise pads, all of these things. It's a big, big market out there, but something that we're not talking about. So being incontinent of your urine is involuntary loss of urine. It can be a dribble, it can be a leak, it can be a flood, depending on the person and the situation. It is not a disease. It is a symptom of other conditions, and it is not a normal part of aging. So that doesn't mean it's not exclusively a symptom that only older people have. Many young people have it, especially women of childbearing age. Often have issues with incontinence following childbirth or during pregnancy. So that's something that people think. I've even heard my own grandmother say, it's just part of getting old. There's nothing I can do. And well, there are some things that we can do, and we can try to make it better. So there are barriers for people being able to be continent and continue to live in independent living. People who are having bowel and bladder incontinence often are self-conscious about it. They're embarrassed. They tend to isolate themselves. As Beth was saying earlier, you might choose not to go to a movie or not go to a dinner because you don't want to have to get up and use the restroom in the middle of it. People are embarrassed because we're not talking about it, or a lot of us aren't talking about it. We're not necessarily sharing with one another, oh, that happens to me too, and this is what works for me. There's not a lot of dialogue going on. You're at risk for pressure ulcers when you have incontinence. Sitting or lying in moisture can affect your ability to have good skin, and that can increase the risk of having a pressure sore. You're at increased risk of having urinary tract infections. And the other big thing is falls. And the reason you're at an increased risk of falls, if you're trying to make it to the bathroom and you lose control of your bladder, people can sometimes slip in their urine, and that can cause a fall. So, signs and symptoms. Having the feeling that your bladder is always full. Increase frequency and urgency to go to the bathroom. This is a big one for lots of younger women after childbirth. Loss of urine when you cough, or you sneeze, or you stand up too quick, or you laugh too hard. You might have some leakage. Maybe feeling a pressure or a bulging in your pelvis. Difficulty initiating urine stream even though you feel like you should be, or having a weak stream, or not being able to completely empty your bladder. So you feel like you have to go, you go a little bit, but you're not really emptying it, and then you still feel like you have to go, and it's kind of this vicious cycle, okay?
So I'm going to talk a little bit about the average normal bladder. Okay, the average normal bladder holds 300 to 600 cc's. So for those of you that are not nurses, that's about 10 to 20 ounces, because I had to look that up. I don't know cc's. But your average bladder can hold 10 to 20 ounces of fluid. And the average person goes to the restroom about 4 to 8 times in 24 hours. That's the typical. Going to the restroom at night when you're sleeping, the normal bladder is 1 time at night. So that is what's considered average. Your bladder reaches full capacity in about 1 to 2 hours after you start feeling the urge to go. Most of us don't make it 1 to 2 hours after the urge to go comes, but that is what they consider average. So next I want to talk a little bit about water. I'm a big believer in water. This is my water jug that I bring every day. Every person should take in about 2,000, 2,800 milliliters per day, which is 71 to 94 ounces of liquid. Now, just know that's not all water. A lot of the things that you eat have water in them, especially fruits and vegetables. But that is what they are recommending. They recommend, as far as actual fluids that you drink, 7 to 8 ounces they say 1 ounce per body weight, but again, that's not your food. So they really recommend 8 ounce glasses of water, which is 64 ounces. But you can get that from any liquid, not necessarily just water. Just remember that some liquids have kind of the opposite effect, like caffeinated beverages dehydrate, alcohol dehydrates. I will never tell anybody not to drink their coffee, even though I work with voice and encourage fluids all the time. It just means you have to drink a glass of water with it so that you keep hydrated. Dehydration is something that, as we do age, becomes more prevalent because the thirst is not there. You don't feel as thirsty. You actually have to make yourself drink more. You know, when you're younger, that is a cue for you. When you are thirsty, that means you haven't drank enough for the day. But as we get older, we lose that cue. So that is something to keep in mind, that you actually have to think about how much you're drinking each day and kind of push yourself to drink a little more.
I've had patients tell me, well, I don't want to drink more water because then I'm going to have to pee more. But it's actually opposite. You want to drink that water so that you're flushing out your kidneys, you're flushing everything out of your bladder. If you're not drinking enough water, you're at increased risk for urinary tract infection, and that irritates your bladder, and that can make your incontinence worse. So that's why you got to drink that water. So there are different types of incontinence. And if you were to see a doctor or a therapist about your incontinence, this would be one of the first things that you would do, is figure out which type of incontinence you're having. So the categories are urge, stress, mixed, overflow, and functional, and we're going to talk about each one, okay? So urge incontinence is that sudden need to go to the bathroom. It's a sudden contraction. You don't have control of it. It's the most common type of incontinence in older adults. You have to go now, and that doesn't mean in 10 minutes or 15 minutes. It means now I've got to go. And so that's when people will tell me, I don't make it to the bathroom in time. I feel I need to go, but I just don't get there in time to be successful. If you are going to the bathroom in the middle of the night more than one time a night, that is considered abnormal. It's okay if you get up one time a night, but if you're getting up 4 and 5 times a night, that's considered an incontinence issue and something that you're going to want to work on, because you're losing some really valuable sleep. And you're going to feel a lot better if you don't have to get up 4 and 5 times a night. So even being able to reduce that to twice a night could make a huge difference in your quality of life. Sometimes this could be related to other conditions like Parkinson's, dementia, MS. Having a UTI is going to make you go more frequently. And the thing to remember is it's that quick and strong, I've got to go now, can't get there. So that's urge incontinence. The next type of incontinence we're going to talk about is stress incontinence. So with stress incontinence, the muscles are not holding everything like it's supposed to be when you're exercising, coughing, sneezing, laughing. Sometimes, you know, you think of little kids when they have to go to the bathroom, right? And they're kind of bouncing and they're crossing their legs. If we do that, it might help us hold it a little bit longer, but probably not long enough. And if we start giggling or laughing, it's all over. So sometimes this can also happen when we're helping someone get up. So if you're really having to strain to stand up, those muscles start not working, and that's when you can have some leakage there. People who have stress incontinence tend to sleep through the night, so that's the positive of the stress incontinence, but they tend to go to the bathroom a lot during the day. One way that you can kind of compensate for stress incontinence is making sure that you're emptying your bladder frequently enough. If you let your bladder get super, super, super full, then when you laugh or sneeze or cough, there's no room for error. So kind of staying on top of making sure that you're not allowing your bladder to get too full can help some with the stress incontinence. So mixed incontinence is just a combination of the two, where you have some urge and some stress, and that's what's most common in women. So a little bit of both, especially as we get older. And then our next one is overflow. So this is when the bladder is full, but it can't be emptied. And that's when you'll hear people say, I kind of dribble. I take longer to go to the bathroom. You have a weak flow. They never feel like they're emptying their bladder all the way. It's rarer, it's more common in men, often related to an enlarged prostate. So just that kind of constant dribbling, and never fully emptying. Also places you at risk for urinary tract infections. If we're not emptying our bladder all the way, we're more likely to get a urinary tract infection. And then functional incontinence is when you know when you have to go to the bathroom, you can feel it, but maybe because of a mobility issue or a cognitive issue, you can't get there in time. It could be from a medication you're taking that's irritating your bladder that you can't get there in time. Maybe you're somewhere where there are no bathrooms nearby and then you have an incident. But again, we can sometimes change your environment. We can talk about locating where the bathrooms are for the places that you want to go so that you can get there when you need to. Physical therapy to help with mobility, to make sure you're able to get out of your bed and be able to walk to your bathroom, are all things that can help with functional incontinence. One thing that I think it's at the bottom of this slide that's not talked about enough when we talk about incontinence are bladder irritants. Now, the slide says cranberry juice. I personally don't agree with that. I would cross cranberry juice off the slide if I had written the slide. But there are things that we eat that can irritate our bladder and make our urinary incontinence worse or more pronounced. Things such as alcohol, caffeine, acidic foods, those orange juices, and it can be a little different for every person. And it could also be the volume of it. From personal experience, I can tell you that strawberries were an irritant for me. I thought I was being healthy, right? Where berries are good for you. We're supposed to keep our brain strong and eat lots of berries, and I was eating really large amounts of strawberries on a daily basis, probably a cup or more every single day over, year round. When I stopped eating that volume of strawberries, I'll still eat strawberries, but I'm not going to eat a cup a day, I noticed that things changed with my bladder. So sometimes people will tell me, well, I'm not going to give up my coffee. You don't need to give up your coffee, but maybe if you're drinking 4 cups of coffee, maybe you can get away with 1 or 2 and see if that changes your symptoms. A lot of sugar or a lot of even artificial sweeteners can be a bladder irritant. But I've seen this work many times with people when they change some of their diets. They tend to have some improvement in their symptoms.
So just piggybacking a little bit on what she talked about, since I was talking a little bit about increasing your water intake or your fluid intake. For me, caffeine is an irritant, but I do drink coffee every morning because I like my coffee, which is why I won't take that away from anybody ever. But I do know that because it's an irritant for me personally, if I'm going to be driving on a trip or not going to be able to access a bathroom quickly, then I do not drink my big cup of coffee first thing in the morning. I will wait and enjoy that when I'm going to have access to a restroom. So that's another thing, is talking about timing of things. And Jennifer will probably talk about this a little bit more later when we talk about what things you can do. But when we're talking about drinking a lot of fluids, I personally drink that huge container of water every day. However, I do not drink after dinner because I do not want to get up all night long. So there is ways to look at your day and fit the fluids into when you have access to the bathroom more frequently. So moving on, what can we do about our incontinence? What are some of the things that we can do to help? This is something that you would want to, very first thing, talk to your physician, because whether you're going to be managing this medically or through some therapy, either way, your physician would be the person that would have to direct that. So if you are struggling with this is something you should be talking to your doctor about. As far as what can be done medically, there's a lot of different things that can be done. I am not a doctor, so I will not give you specifics, but we'll kind of review some of the options. But I will tell you, not everything works for everybody. Everybody's body is different, and what helps for some will not always help for others. So it is definitely something you have to talk to your doctor personally about your needs. But there are medications that can help, so the doctor may prescribe something for you. There are devices that they are using now to insert to help with incontinence. There are other type of things like injections, Botox and other injections that can be utilized to help strengthen the muscles and prevent the leakage. And then there are some surgeries out there that are also something that can be done to help with managing incontinence. Again, these are all something you would speak with your doctor about, and then maybe a referral to a urologist, of course, if you're going to look at medical management of it. But those are some options out there. What we can talk about is what we can do from a therapy perspective.
So an occupational therapist or a physical therapist can evaluate your pelvic floor muscles. They're going to use evidence-based assessment tools to establish a baseline of where you're functioning at. If you come and you do this, as I like to say, we're going to be all up in your business. We're going to be asking you lots of personal questions about how many times a day do you go to the bathroom? How many times do you go at night? How are you leaking? How many pads are you using? How many Depends are you using? It's very, very detailed. We're going to ask a lot about how much liquid you're drinking, when you're drinking it. We're going to ask you about the bladder irritants. What are you eating? So it's very individualized to you and what your symptoms are. We will work on bladder retraining program, try to improve your bladder control, and do some evidence-based exercises to help strengthen your pelvic floor muscles so that you hopefully will then have less episodes of incontinence. So I have a couple slides that show you your anatomy. This is female anatomy. You can see where your pelvic bone is, and you can see the pelvic floor muscles are kind of that orange-like around the rectum, the bottom of the rectum, all the way up towards your pelvic bone. And again, they're kind of hammock-shaped, and they're holding everything in place. And if those muscles get weak, things can start to droop down. So then we're not holding things in a good position, and then we're more likely to have bladder leaks. Those muscles also help us with holding our bladder when we need to until we can get to the bathroom in time, or being able to hold it for increasing amounts of time. And then the next slide is the male anatomy, and they also have the pelvic floor muscles. They're still hammock-shaped, just slightly different location, but you can see those are the muscles we're talking about strengthening. So it's not as easy as doing a bicep curl, right? We all can see our biceps. We know exactly where they are. We have to learn when we're getting these muscles and when we're strengthening them, and it takes a little bit of practice. You can if you're sitting here, you can most likely activate your pelvic floor muscles if you squeeze the musculature in that area, that as if you were trying to stop yourself midstream if you were voiding. So if you think about the muscles that when you're voiding, if you stop it and then start it again, those are the muscles that we're trying to strengthen. You can be sitting here and tightening them and relaxing them and no one would ever know. But that's the muscles we're aimed at. So sometimes we recommend toileting programs. That might be every 2 hours on the dot, whether you feel that you have to go to the bathroom or not, you go and try to go to the bathroom every 2 hours. Sometimes I'll have you do a voiding diary, where you're gonna take a week or two and you're gonna write down all the times that you've gone to the bathroom. So then we can kind of see what's the pattern here. And then I like to superimpose that with, well, when were you drinking your liquids? And when did you stop drinking your liquids? And we're kind of looking at your day so that we can come up with a prompted time to void and use the bathroom. Sometimes we need to relax our body. So sometimes when we get that urge to go really fast, we get panicked about it and we've got to get there really fast. But if sometimes it might just be 30 seconds, but we'll start working on, okay, I feel the urge. Let me see if I can hold it and let's relax. And there's some things that we can do to relax to see if we can wait 30 seconds before we get up and go to the bathroom. And then after you're able to do that for a little bit, let's see now, can we wait a minute? And then work it up to maybe 5 minutes, 10 minutes. That can really also make a difference too. And knowing that you can hold your bladder for a little bit longer. Clothing adaptations are just, what can I wear to make it easy for me when I get to the bathroom so that I can get my clothes on and off and that not be a barrier to me. So if we've gotten arthritis in our fingers and we're having trouble with, certain types of buttons, we might look at that. We might suggest elastic waistbands, zipper pulls to make it easier to pull up and down a zipper. Those are all like types of things we might do. Environmental modifications, I think we talked about that a little bit earlier, making sure you have a clear path of travel, making sure it's easy and safe for you to get up and down from your commode, making sure that you can reach safely the products that you might need to use. Those are all things that we would look at in therapy. We talked about the dietary management. We do have a dietitian here at Cedarfield, and she would be another resource that we would refer you to talk to her about the bladder irritants, as well as how much liquid and what percentage of the food you're eating is providing you liquids. Even looking at menus with you, she can sit down and look at a Cedarfield menu and help you with decisions about food selections that may help. The pelvic muscle exercises are probably the biggest thing that almost everyone needs because those muscles tend to lose their elasticity and they're not as strong. So again, we would sit down with you and customize an exercise program and make sure that you're completing them correctly, because sometimes we think we're doing them correctly, but we're not, so that you could start to strengthen those hammock muscles that are going to help you be able to control your bladder and keep everything in place. If those exercises don't work, some people need electric stimulation of those muscles. That's not something that I'm certified to do, and that there are therapists who have certifications in that, and we can refer you to a different provider that could do that. But that's just using electrical stimulation with probes and at the correct points to give you internally muscle contractions. So that's a lot of information. Let's have questions. What can we answer for you?
At the very beginning, you mentioned about it's a symptom of other conditions. What other conditions are we talking about?
I would say Parkinson's, dementia, MS, ALS. But just because you're having urinary incontinence doesn't mean you have one of those conditions. It just, urinary incontinence tends to go hand in hand with those conditions. You can have urinary incontinence alone, just as itself. Yes.
I think a lot of times we don't think about, but they're muscles. And just like any other muscle in your body, as we get older and we're not using them the same, they get weaker. Our legs get weaker, our arms get weaker. These are muscles too. So it's not always correlated with something else.
Yeah,
We'll
no
make
need
that-
to panic.
What other questions, comments?
I have had friends who've had surgery for this condition. What is done during surgery?
I'm going to let you answer that, Beth.
Okay, as the speech therapist. No, I'm just kidding. There are different types of surgeries. I can only speak to one because I have a family member that has had it. They had a sling put in, which basically went in and held the bladder up because the muscles were no longer able to do that. And that has helped a lot for that individual. That individual also tried a device that was inserted. It's a pessary. It's something different to help with the bladder. It didn't work for her. It has worked for other people that I know, but it didn't work for her, so she ended up having the sling procedure done.
What does the sling procedure involve?
That you would have to ask a physician because I do not know the details in that specifically.
That sling procedure is just one surgical procedure that can be done. There are different surgical procedures depending on the type of incontinence you have, because anatomically there are different problems depending on the type of incontinence that you have. So the procedures would be tailor-made to the type of incontinence that you have. Also, it was mentioned there are certain injections that can be used that's just done in the doctor's office, such as Botox. A gel material can be put in there. And also the pessary that Beth alluded to is a very, very simple procedure. It's not even really a procedure, it's a device. It's a rubber device that the this is for women, that a urogynecologist or which is usually the person that deals with this, they're called a urogynecologist. And they would examine you and determine the best size for this pessary. It's a rubber device that's just put into the vagina, and it just stays there. And then you go back every 3 months to the doctor. They remove it, clean it, check, make sure everything's okay, and they put it back in. So that's a simple procedure that, as Beth mentioned, didn't work for her family member, but is a very easy procedure and is very useful and works well for others.
And I've had people that I've worked with who have had Botox injections, and those have been quite successful for some people. But it's not like you get it done once. It's something you have to, go back every several months.
And again, it's all going to be specific to you and what your incontinence is and what your anatomy is to what would be the best thing for you. And that's why you would have to go and consult your physician. We really couldn't give you a suggestion for that.
I'm not a very good water drinker, and I need a reminder about how much water we should be drinking.
Okay. A lot of it depends on what else you're eating, because like I said, there are a lot of foods that you do get water from. So if you're a person that eats a lot of fruits like watermelon or vegetables like cucumber that have water in it, you are getting extra. But what they recommend are 8 ounces, which is 64. That's a lot of water. Other fluids are also hydrating. Obviously,
This is 64.
that's 64 ounces right there, which again is a lot of water. A lot of people don't feel that thirst. So what I recommend is have a small water bottle that you can refill in your bag or in your walker or in your purse, and then try to think about how many times a day you're refilling that. Because I think the visual, like everybody says, oh, well, I drink all day long because I drink when I take my pills. Well, you took 2-3 sips. So maybe having a small water bottle would help with being able to keep up with how many ounces you think you might be drinking.
I'm not a good water drinker either, and so all of my friends carry these big things around, and this overwhelms me. I feel stressed out when I look at this. So instead, I do half that size, 32. I find that to be less scary, and then I try to refill it sometime during the day. But if I look at that, I'm just like, oh, I can't do that. I'm going to float out of here. So you can put lemon juice or lime juice or a sliced strawberry, something to like maybe make it taste a little bit better that might entice you more. And I don't like drinking room temperature water, so that's why I use like one of these insulated cups that keeps the ice in it all day, and that helps me too if it's ice cold. But
And then also sometimes having a schedule, like for me, I'm in and out of my office and I don't carry that water bottle with me. I just brought it here to show you all. But so I have kind of a schedule in my mind. I know I have a meeting at this time. I make sure that I'm at this level by that meeting. So same thing, maybe you have a cup of water by a specific time and you kind of set that schedule in your mind. Milk is a fluid, but not quite as hydrating. But yes, it is still a fluid. Yes, absolutely. All of them are. The only things that they usually will not count are caffeinated beverages or alcohol. So juices are also a liquid. Decaf tea or decaf coffee.
You might talk about functional pathways and who you are and the fact that you're not team members here, but a contract group.
Sure. So we are, like you said, Functional Pathways. That is the company that we work for, and we are contracted here at Cedarfield to provide physical therapy, occupational therapy, and speech therapy. We work all over the building, independent living, assisted living, and in healthcare. So we are the therapy providers for anybody who wants to be seen in the facility. Now, of course, there are lots of rehab companies out there, and some of you all may have a therapist that you've worked with for years. But if you would want to have services here, we are the company, and we have PT, OT, and speech all here, 5 days a week.
A comment on how to motivate yourself to drink water. There are apps you can put on your phone that will beep at you, and every hour will remind you to drink some water. If you're not that technologically inclined, you can set a timer. You can on your phone or in your apartment. Or what I do is I put that much water in a pitcher in my refrigerator, and I tell myself I can't go to bed till I drink it. It becomes problematic when I've been away all day and I come home and I look at that and I'm like, nah, I can't do that because I'll be up all night. So sometimes it doesn't happen, but it is a motivating factor, and it makes me go in the fridge or carry around my bottle with me when I run around. I always have something in your car. Take a little Yeti like that in your car and say to yourself, okay, I'm going to the grocery or whatever, and I'm going to drink all that before I get home. It's just little mind games, like Beth said, that to make you
and if this
more aware.
doesn't stress you out, this actually has times written on it that's supposed to motivate you. So by 11 o'clock, Beth was supposed to drink to here, and she has. She's been very compliant today. 1 o'clock, it kind of divides it up. So this gives you a visual motivator.
Are you going to read the motivations on there? What's 11 o'clock?
11 o'clock says hydrate yourself. 1 o'clock says keep it up. 3 o'clock says you're halfway there. 5 o'clock is you can do this. 7 o'clock, don't quit now. And 9 o'clock says it's all in a day's work. So.
Well, I can tell you I skip 7 and 9 because I drink all of that before dinner because, again, after dinner, not for me.
In the most recent Costco magazine, they had a thing about incontinence.
Oh.
And they listed things that you should avoid eating. One of them was chocolate, so we closed the book right away and read on. But it didn't say any particular foods. I've noticed that if I eat a lot of spinach and leeks in particular, I'm running to the bathroom. Are there particular foods that we can avoid?
The ones that we list, asparagus is one for some people that can make you have to, it goes through you quickly, so they say. Iced tea, tea often kind of can go through your system quickly. Caffeinate, and the reason chocolate falls under there is because of the caffeine. So your caffeinated beverages, your acidic fruits and juices, so your oranges, your I don't what else. I mean, for me, it was strawberries, tomatoes. And again, think about moderating how much. It doesn't mean you never can eat chocolate, but maybe don't eat a bunch of chocolate and drink a bunch of coffee and have a Coca-Cola, right? All in the same day. Like try to moderate it.
And if you do find something, then awareness is half of it right there. You know, if you eat that, you need to be right next to the restroom, or it needs to be very available to you. So that's how I am as far as, for coffee. If I'm going to drink it, I need to not be going into a meeting for an hour because it's not going to work out for me. So.
I just share some information for the group, and I know men and women are different, I think, but I have had a lot of experience with some of the things you're talking about. Several times I've been to the clinic, and I thought I had and it always boiled down, they told me I was dehydrated, and I didn't pay a lot of attention to them. I have had prostate cancer, so I have an issue there that I've learned to train. But what I wanted to say to you, I have a private caregiver helping me some now, and she about driving me up the wall, forcing water on me. She has taught me how to drink water, and it has helped. So I can tell everyone, it helps in your bladder. It has done. I would urge people, you think you're drinking water. I thought I was drinking water, but the way she hands those glasses to me and I have to drink it, I said, damn. But it's working. It's working.
Thank you for that.
Thank you. Does anybody else have anything? No? Well, oh, yes, ma'am.
I go to the bathroom and think I'm finished. And I am finished as far as any more water coming out. So I put on my britches and I get to maybe not very far before I have to go again. And how do that frustrates me because I want to change my britches again.
Okay, so that's more retaining.
Yeah, so probably you feel like you're fully emptying your bladder, but you're probably actually not. One trick you could try is to lean, when you're sitting on the commode, to lean yourself forward, like bend forward, to make sure you're compressing your bladder. Sometimes that helps to kind of squeeze a little bit more. If not, that might be something that you want to look at talking to a doctor about, maybe seeing a urogynecologist or getting a referral for therapy where we could work on trying to strengthen some of those muscles to make sure that they're contracting enough, and also that your sphincters are relaxing enough that you're able to relax your sphincters to allow you to void fully. So yeah, you're welcome.
Just as a resource, Virginia Urology has urogynecologist. I go to one, and they're very good.
Yes.
So the comment, in case you couldn't hear, is Virginia Urology has urogynecologists if you are looking for somebody.
Yeah.
And Also, most regular gynecologists have one on staff as well, the big practices.
Yes.
Yes. Yep. Any type of therapy, whether it be physical, occupational, or speech therapy, does require a physician order, even if it's for, urinary incontinence and training. Thank you all. I know this is not an easy topic to talk about, and not everybody might have wanted to come out and listen to it, so I appreciate you all being here. And if there's anything we can do to help, just let us know.
Thank you.